So we'll start our study with cases of the circulatory system, heart and vessels. So here we have a coronary artery. You see the media, the muscular layer, and you see that a great part of the inner layer is thickened. This part here is of normal thickness. By comparison, you can see how much thickened this part of the vessel is, because atherosclerosis is a lesion which is segmental. It does not affect the whole inner layer of this medium-sized artery, because atherosclerosis affects medium and large-sized arteries. So, what do we see in the atheromatous plaque? We can see some cholesterol clefts, which is a foreign body. These are the cholesterol clefts, which is a foreign body that is deposited down the endothelium, so it is a foreign body and causes inflammation. So we can see the macrophages, here they are, we can see their nuclei related to the cholesterol crystals. So here are the cholesterol crystals and here are the macrophages. Being phagocytes, the macrophages have enzymes which, when secreted, soften the plaque, and this is not a good sign because it might rupture. Of course, if the plaque is very hard, it's not always for good, but when it is softened by the enzymes of the macrophage, this may more easily lead to its rupture. Since the macrophages stay there, they help collagen and fibrous tissue deposition because they secrete fibrogenic factors. And these fibers, this fibrous tissue, increases the size of the atheromatous plaque, so the lumen becomes more narrow. As the size of the atheromatous plaque increases, the lumen is occluded. And when this occlusion affects more than 75% of the whole lumen, then the patient may have angina, stable angina symptoms. So here is the fibrous tissue, increasing the size of the atheromatous plaque, the cholesterol clefts, needle-shaped, and the macrophage. So what happens? This is the place where the inner layer of normal thickness transmits to the thickened inner layer due to the atheromatous plaque. So when the blood presses this area, it causes erosions. And when eroded, all the small vessels lying beneath, let me see if I can find one. You see here that we have, this is the fibrous capsule of the atheromatous, and this is the place of its transition to the normal size. So in this place, if we have erosion, there might be hemorrhage from the ruptured capillaries, and when this happens, what will be formed there? If we have a hemorrhage here in this area, if we have some rupture of small capillaries, a thrombus, a clot, and so the whole lumen may become occluded, or the clot may leave and be an embolus and go and will have an embolism in some next part of the coronary artery. And what is the result? Is the acute infarct of the myocardium. So these are the constituents of the atheromatous plaque. Please have a look, because we have an online transmission through my channel. Just check, please, that we have there is live streaming. You please open my channel and see if we have the video, because it will stay there for the other students and for you, of course. Yes, live streaming, yes. So you can watch the video and learn what to define in the histologic slides. Yes, please.
So what do you have to define for this particular?
We have the cholesterol deposition. We have the macrophage, the fibrous tissue, and the vulnerable point, which is where the normal size of the inner layer of the normal size goes to the area where it is thickened. That's all. Furthermore, here is some part of the heart. You can see the myocardial fibers. And let's have a look at the other slide of atheromatous. Again, here are the constituents of the atheromatous plaque. The cholesterol needle-shaped clefts here. The macrophages, here they are. They are foamy macrophages because they phagocytose the lipids here, the lipoid substance here that you can see. So this is the part of the atheromatous plaque. Yeah.
So the endothelium that forms above the fibrous layer of the plaque,
yeah,
it's functioning normally?
No, there is always a dysfunction in the endothelium when an atheromatous plaque is formed. However, in order that there is an acute phenomenon and that causes the thrombus, this endothelium should be eroded. So it's like an ulceration of the endothelium. So if there is an ulceration or an erosion, a microhemorrhage may occur, and so it will cause thrombosis. Yeah.
Was the lipid substance formed by the macrophages?
The macrophages go to phagocytose the foreign body. The foreign body are the lipids that are deposited beneath the endothelium. So this is all. And you can see here the media, the muscular layer, because these are muscular, middle-sized arteries. You see here. That's all. Now, next one. This is a case where we have occlusion of the lumen. You see, for this diameter of an artery, the lumen is too small here, too small. But it is not a case of atheromatous plaque, because here the occlusion of the lumen is caused by inflammation. So this is an immune type of inflammation, because this is vasculitis, and it affects the temporary artery, so it is called temporary arteritis or giant cell arteritis. So let's have a look. You see all this damaged tissue here, and of course you see the inflammatory cells. If we have destruction of some cellular elements, we may find some neutrophils. However, since this is an immune inflammation, which cell do you expect to predominate? Since this is an immune inflammation, identify these cells, please. Lymphocytes, yes. So it is a mainly lymphocytic infiltration in the wall of the artery. Here we see the intima, the inner layer. However, what is typical is that you frequently find all these multinucleated multinucleated giant cells in close relation to the, this is the border between the inner layer and the medial layer. It is called the inner, it is an elastic tissue. Can you help me? The lamina, how is this called? Yeah?
Elastic lemon.
The lamina, yes. And this is phagocytosed by these giant cells. Thus, the term giant cell arteritis. So you can show me the giant cells. You see? Here they are, multinucleated. The remnants of the lamina, here, you see that it is disrupted. Look here. It is not continuous. It is not continuous. It is broken. It is broken. You see the lymphocytes, the main factors of inflammation, of immune inflammation, and furthermore, what do you see here? You see that the lumen is greatly narrowed, and what is this here? Which might cause a severe problem, especially if the ophthalmic artery is involved by the inflammatory process. What is being formed here in this part? What can this be? Look, it's something within the lumen, So, a thrombus, yes, this is a clot. So, we understand that arteries are not only occluded by atheromatous plaques which have become complicated and eroded and thrombosed, but an immune inflammation and arteritis may also occlude the lumen through thrombus formation, because since the inner layer is thickened again, there is not enough blood supply. And what symptom does this cause to the patient? He'll have headaches with temporary arteritis. And if other arteries are involved by the inflammatory process, he might have pain when chewing and other problems with the eye. So this is a vasculitis, and as all immune-mediated vasculitis, they may become clinically apparent by infarcts. For example, nodular polyarteritis causes infarcts. So have a look at the broken elastic lamina, the inflammatory cells, the giant cells, and the narrowing of the lumen. That's all in this slide of giant cell arteritis. Here is the media, the muscular layer, and you see there are also some neutrophils, perhaps due to the destruction of some cellular elements, they come here. However, it is an immune-mediated inflammation, acute, not in the sense that the exudate mainly consists of neutrophils. There are neutrophils present, however, the inflammation is dominated by lymphocytes, which attack the elements of the tissue itself, so this gives it an autoimmune pathogenesis. Now we'll have a look at the consequence of the previous slide lesion, the atherosclerosis being complicated and the thrombosed, acutely thrombosed coronary artery. So we see the place of coagulative necrosis in the heart, namely the infarct. Pay attention here. All these myocardial fibers are necrotic. How can you tell? There is no striation, and more importantly, there are no nuclei, because these myocytes are dead because the blood supply was abruptly inhibited by the clot, clot that was formed in the lumen of the artery. So this is an area of hyperacute infarct, because we see these necrotic myocytes of the myocardium. However, you see how broken they are. You see how discontinuous they are. Why? Because there was an abrupt, yes? Okay, thank you. Bye. There is an abrupt occlusion, so we have the coagulative necrosis. However, the inflammatory cells have not yet come, so it is about 5 hours, up to 6 hours after the onset of the infarct. It's very recent, it is hyperacute. But after 12 hours, the neutrophils come. So you have the acute infarct. Here you can see that apart from the necrotic myocardial fibers, there is an increased number of infiltrating neutrophils, very easily recognized by the configuration, the lobulation of their nuclei. So this is the acute infarct. It's very easy to recognize it. Mainly neutrophils infiltrating. And furthermore, in the same slide, you can see an area here in the center where there are no myocytes, necrotic or viable. And what tissue is this that has replaced the myocardium? You can see some spindle-shaped shells like these depositing these fibers. So, can you identify this tissue, which is the consequence of the organization of the previous side we saw? That means we had the neutrophils, then we had the macrophage. So this is granulation tissue formation. And by the way, during the phase of granulation tissue formation, most fatal complications of the infarct may occur, because this early granulation tissue is friable, and so it may break. And you can understand that blood will leave to the pericardial cavity and will have cardiac tamponade as a consequence, complication. So, however, if the patient does not have this complication, the organization of the inflammatory exudate will form this tissue. This is desmoplastic reaction leading to a scar tissue. And when we see such large areas of scarring within the myocardial tissue, we understand that this is an old infarct from which the patient has survived, and we have the continuity in the wall of the necrotic area by scar tissue, by fibrous tissue. So this is the area of the ancient infarct, the old infarct. And apart from the fibroblasts, you can find some cells of chronic inflammation here. Namely, which cells are here? That denote, that make us think that this is an area of chronic inflammation. What cells are there found in this old infarct? Yes. Mononuclear cells, and here lymphocytes as cells of chronic inflammation.
Professor, how
Yeah.
does the granulation tissue look?
The granulation tissue looks like a tissue with a mixed inflammatory infiltrate, neutrophils and mononuclear cells, newly formed vessels, and some fibroblasts which gradually progress to scar tissue. However, in this case, we do not see the area of the granulation tissue, but on the background of the old infarct, we have a recent one which killed the patients, probably due to arrhythmia, because this is the most common fatal complication in the first 2 days of the patient after the infarct. So he had a fatal arrhythmia that stopped the heart. So what do we see? We see all the evolution of the infarct, an old one from which the patient has survived, and a hyperacute one where the inflammatory cells have not yet infiltrated there, and the recent one. So the cause of death here is most properly not a rupture of the heart wall, but a fatal arrhythmia, because especially in the area on the border of the necrotic tissue, this is called penumbra. This area is responsible for all these disorders in the heart rhythm and causes arrhythmias, which sometimes may be fatal for the patient.
Sir,
Yeah?
is the pericardial effusion, the exudate, normal in such cases?
It's not totally normal, but it has been described because since we have some sort of damage, this may reach the pericardium and cause some sort of an exudate collections. It won't be an abscess unless a bacterium superimpedes and makes an infection. It most probably will be serous as a marker of some sort of pericardial damage. However, we'll see the pericarditis slide because this area is lined by mesothelial, since it is the pericardial sac, and in such areas the inflammatory exudate may be serous, but it may also be fibrous. And I think that in the pericarditis slide we are going to study, we can see the fibrinous exudate, which will, if organized, will entrap the whole heart in it. So we leave this slide and we'll try the myocarditis. What do we see here? In contrast to the infarct, in which the inflammatory process is limited to the necrotic area, in the myocarditis specimen, we can see lymphocytic aggregates throughout dispersed in various areas of the whole myocardium. Of course, this is an autopsy specimen, so we can examine the whole heart. Very rarely are biopsies taken from hearts that we suspect have myocarditis. Nevertheless, here we can see a sign of inflammation which is related to the increase of the distance between these damaged myocardial fibers. This is a key sign of inflammation, because here one might think that this could be fibrous tissue. However, if he performs a Masson stain, it won't stain green to blue. It will not stain at all. So it is not fibrosis. And what else, what other sign of inflammation may be related to this increase in the distance of the damaged myocardial cells? Remember the signs of inflammation and you'll find it. No? What can this be? And we have this increase in the distance of the damaged myocytes. Yep.
I would say due to the increase of the pressure, it will
Yes.
press.
Yes, increase of the pressure. However, this is due to an exudate formation here. So, what is that?
Is it the inflammatory exudate?
The inflammatory exudate, however, here we see it as edema. This is edema. That means due to the exudate, which is a transudate, I do not see that it consists of protein so much because this is probably to virus. Myocarditis are related mainly to Coxsackie viruses infection. However, we can see the edema, the inflammatory edema, and furthermore, here is an aggregate of inflammatory cells, the morphology of which is consistent with the viral etiopathogenesis of the infection, because when we have viruses as infectious agent, the inflammatory exudate consists of which cells? Here they are. Look at them. Lymphocytes. Yes, we have a lymphocytic infiltrate. And in many areas, you find these lymphocytic aggregates throughout the myocardium. Here, another smaller aggregate here, and this helps in the differential diagnosis of an infarct because these lesions are throughout the myocardium. And here, what can this be? Here, perhaps we are close to the valves, and this could be, you remember the papillary muscles, the papillary muscles, probably here, I'm not sure, but they look like. So that was the myocarditis, and here we have the myocardiopathy, which is of the hypertrophic type, and the weight of the heart is significantly increased. And what we can see from a histologic point of view is some sort of disorganization in the array of the myocardium fibers. You see that they are somehow not so well orientated, and perhaps some areas of fibrosis as well. However, none of these findings is that specific as the increase in the weight of the heart, which causes some sort of an asymmetrical disfiguration in the left ventricle, which as a consequence it cannot be filled with blood, and then it cannot send enough blood to the periphery. That's why this entity, hypertrophic myocardiopathy, is related to episodes of syncoptic episodes, mainly in young athletes during stress in a game. So this is hypertrophic myocardiopathy. Here is an area of fibrosis. And the last slide is this one, pericarditis, where we have some sort of damage in the pericardium. Here it is. This is the visceral layer of the pericardium. And can you see here what sign of inflammation is present here? Histologically, what kind of inflammation is this? You see all these capillaries being thus filled with blood. This is congestion in the microcirculation of the capillaries. And this is how inflammation starts, due to the chemical mediators, histamine and other vasoactive amines. More blood is sent to the area where the damage took place, and so we have congestion in the capillary circulation, evidenced here. And look at this. Here they are. This is the fibrinous exudate. We can see this sort of exudate here on this surface, this is fibrin, an acellular constituent of the exudase, which when inflammation persists, these fibrin parts become organized and form strictures. And so we have constrictive pericarditis. It's similar to what happens in other cavities in the human body lined by mesothelial cells, the pleura and the peritoneum. Inflammation there, when organized, since the inflammatory exudate is rich in fibrin, may form strictures. And we have obstruction of the bowel, constrictive pericarditis here, or pleuritis, the pleuritic pain in the pleura. Yes, so that's all from the pathology of the circulatory system. We won't have the pathology of the respiratory system because I have uploaded the relevant archive in the 12th playlist. You'll find respiratory pathology microscopic study of virtual slides. Yes, please.
For the slide you did on the hypertrophic
Myocardiopathy.
would we not see atypical?
It's not one of my favorites because I'm not sure about the disorientation of the fibers. I cannot understand that very clearly. So I won't ask it. I think I won't ask this slide. It's been described in the literature. However, I'm not sure because you must always have what the normal is to understand the disarray of the myocardial. And I'm not so strong on circulatory pathology, on heart pathology. So I don't think I'll ask this slide. If I ask it, you just tell me that the main feature is the increase in the weight of the heart. It's about more than 350 grams. It reaches half a kilo. This is very common. And what you see, it's mainly a macroscopic diagnosis because you see some sort of bulbous enlargement of the ventricular diaphragm and some asymmetrical configuration of the left ventricle. These are the key features to diagnose the hypertrophic cardiomyopathy and not so much the histological findings. It's what you see at autopsy by the eye, macroscopically. Yeah. Okay, shall we pass now to the GI? Okay. Now we have the GI tract. Here we are. Let's start from the stomach. The stomach. Look at this slide. Here is the mucosa of the stomach. Not only the mucosa, we have the muscularis mucosae, here it is, the submucosa, and the muscular layer, and the subserosa. Now, let's have a look here at the mucosa of the stomach. I can see these parietal cells, so I can understand that this is oxyntic mucosa. It is in the body or up the stomach, not close to the pylorus. It's close, it's to the main body of the stomach. So, can you see the inflammatory cells? Here they are. They are in the lamina propria among the gastric pits. So, this is a superficial gastritis of the chronic type because the cells we find here are mainly mononuclear. And furthermore, they are the typical cells of chronic inflammation. Can you identify these cells, please? Can you identify these cells? These are plasmacytes, all right? The cells of chronic inflammation. So if you find some neutrophils as well, like here, if you find some neutrophils, then there is some sort of activity in the inflammation. However, the gastritis is chronic because you see plasmacytic infiltrates. Here we have superficial gastritis. As far as terminology is concerned, if you meet the term acute gastritis, this does not mean that it has neutrophils, because acute gastritis is an erosive gastritis. It has to do with a stressful factor, possibly alcohol or something else. So in acute gastritis, we just have an erosion of the superficial mucosa and not necessarily increased number of neutrophils. So if we see neutrophils in the gastric mucosa, it is more commonly in the context of a chronic gastritis with activity. So the neutrophils denote the activity of a chronic gastritis. This gastritis was superficial. However, this is not the case with this gastritis. Note the difference. It is very clear. Look, here we have another type of mucosa in which, in the deep mucosal epithelium, we cannot identify parietal cells. These are pyloric type glands, so we are close to the duodenum in the pyloric antrum. And what else do we see here? Look, we have all these lymphoid follicles displacing the deep mucosa of the stomach, of the pylorus. So, since there are no glands here close to the muscularis mucosae, look at the muscularis mucosae, there are no glands here, we have lymphoid follicles, so this is atrophic. This is atrophy of the gastric mucosa. This is atrophic gastritis, and since there are so many lymphoid follicles, it is most probably of Helicobacterium etiopathogenesis, in contrast to the previous gastritis that we saw in the body of the stomach, where you might think that it might start from the pylorus and continue to the body, so it would be an extension of an helicobacteric gastritis. However, there would be a possibility, if we had atrophy in the previous slide, that we have an immune gastritis in the mucosa of in the oxyntic mucosa, which, when destroying the mucosa and making it atrophic, it would cause hypochloridria, and this would lead to a defective secretion of the endogenous component, and thus vitamin B12 could not be absorbed in the duodenum, in the small intestine. So this would lead to pernicious anemia. But this would be a consequence of an immune gastritis, not of the antrum, but starting in the mucosa of the body of the stomach, all right, in the oxyntic mucosa. This is not the case here. Here we have an atrophic gastritis in the pylorus. So we see the lymphoid follicles, and it's most probably related to Helicobacter pylori infection, and of course we should give eradication so that the mucosa is cleaned, because all this lymphoid tissue may form a lymphoma, and furthermore it may predispose the mucosa of the duodenum to ulcerate. So, what else do we see in this atrophic gastritis? We see that these glands do not look like gastric peds. Why? Because they have goblet cells. Goblet cells are found in the bowel, less in the small intestine and much more in the large intestine. So here we have a case of intestinal metaplasia of the gastric pits. And we have to see if it is of the colon type, that means if there are only goblet cells, or if there are other cells encountered in the small intestine, such as Paneth cells. And we look very carefully to see if there is a brass border. And this is highlighted with pus stain, because if you see a brass border, perhaps implicated here, this might be due to small intestine type of metaplasia. So if you see the metaplastic tissue, it's good to try to define if it consists only of goblet cells, which is of the colon type, the large bowel type, or if it is mixed and is of the small intestine and the large intestine, as it's most probably the case here. In these cases, however, surgery is not justified unless we have a complication. And the complication is here, where we see that there are no glands in this area, and we have a purulent exudate. Let's have a look. Here we have many neutrophils. That's why I call it a purulent, fibrinopurulent exudate in this area of destruction, of the severe damage of the gastric mucosa throughout its thickness. And furthermore, in the base of this fibropurulent exudate, we see granulation tissue. This is inflammatory granulation tissue, consisted of newly formed thin-walled vessels, a mixed inflammatory infiltrate, neutrophils, mononuclear cells, and some fibroblasts, which gradually will become fibrocytes and will have scarring on the base. So these all are the layers of the ulcer. Furthermore, another part of the ulcer is the necrotic tissue, which may be of the fibrinoid type. It's something like this, implicated here. However, it's more evident the fibrinoid, I think this is fibrinoid necrosis, this area here. But in the other slide of the ulcer, let me see if we have it here, the other ulcer, I think this one, yeah, this one. I think that fibrinoid necrosis is more evident. Here it is, here. This is the inflammatory exudate, and this is the layer of fibrinoid necrosis. You see the necrotic tissue? Why do you call it fibrinoid? Because it's similar to what you see in immune-mediated vasculitis, where you have a fibrinoid necrosis in the wall of the damaged vessels. However, this is not a case of vasculitis. It's on the ulcer. On the ulcer, one of the layers on the ulcer bed. Yes, please.
Do you also see fibrinoid necrosis in malignant hypertension?
I think, yeah. You see that in the vessels. Yes, correct. Yes, this is another case when you see that type of necrosis. Because when you have malignant hypertension, that means that the pressure is 30, the big one, and 15, the other one, the diastolic one, and you see damage in the vessels of the retina. And if you perform a biopsy in the kidney, you see that apart from the thickening of the arteries in the renal parenchyma, in addition to the thickening due to hyaline deposition, you also see fibrinoid necrosis. It's correct. This is another lesion where you can see this type of necrosis. The wall of the vessels in vasculitides, the ulcer bed quite superficially, and the malignant hypertension lesion of the renal parenchyma. Excellent. Now, so we have the fibrous tissue formation, and this disrupts the continuity of the muscular layer. You see here that as the ulcer goes down, you see that the muscular layer is displaced. It is displaced because this fibrous tissue shrinks the area, so it might lead to a complication named pyloric stenosis. And so the food cannot go to the duodenum, and there is vomiting, rather explosive vomiting of the patient. Another complication is that as the ulcer is not being healed and goes down, it may make some vessels to rupture. Have a look at these vessels down here, which are the wall of which is quite thickened. Not so this one. This is a venule. This seems to be an artery, and we don't see a lumen, but I do not think it is so specific because it might be a matter how it is cut and not see the lumen. However, I think that the wall is very thickened, very much thickened. Why? Because of the chemical mediators secreted by the inflammatory cells in the ulcer. This is some sort of obstructive endarteritis related to chronic inflammation, because this was a chronic ulcer, because apart from the activity we saw with the neutrophils in the superficial fibrinopurulent exudate, we saw fibrous tissue. And what's the problem here? If such a thickened wall vessel is broken, is ruptured as the ulcer goes down, this might lead to hemorrhage that needs surgery to stop, because the thickened wall does not have the ability to close on its own as normal vessels do, so it is permanent hemorrhage, so you have to stop it. And sometimes you have to have a partial gastrectomy, including the vessel that gave you the hemorrhage. This is another complication. Next, we have another lesion here in the stomach. Look, here we have something that looks like an erosion or an ulcer, because here we have the muscular layer, the submucosa, and the mucosa. Look here. You could think that this is atrophic gastritis. However, if you look very closely, you see that apart from the inflammatory cells, look, plasmacytes, there are some other cells which you cannot tell what they are. And this makes you suspicious. Now, have a look at these cells here. Here we see plasmacytes. Okay, we have inflammation. This might be an eosinophil. However, there are some cells that you cannot tell what they are, these cells here. So you must perform an immunohistochemical stain against cytokeratins. Look here. These cells have a signet ring-like appearance. You see the nucleus being displaced at the cell's periphery? Signet ring. signaturing cells. These are malignant cells. It's a diffuse type of gastric cancer. And of course, since you do not see glands, you just see single cells invading the lamina propria, it is of course high grade. It is poorly differentiated because these are single cells, malignant cells. However, the crucial factor in gastric cancer, here these are poorly cohesive cells of the relevant cancer. All these are cancerous cells. And of course there are some coexisting inflammatory cells. However, it is whether they invade in the muscularis propria. Because if they invade the lamina propria, invade the muscularis mucosae, enter the submucosa, all this is gastric, is early gastric cancer. You have to perform gastrectomy because lymph node metastasis is possible. However, prognosis is rather good. Prognosis worsens greatly when we have invasion of the muscular layer of the gastric wall. The survival rate drops dramatically. So it is of crucial importance to diagnose gastric cancer when the invasion does not affect the muscular layer. And this is such a carcinoma which, despite its poor differentiation and poorly cohesive type, which is frequently accompanied by E-cadherin immunonegativity in the carcinomatous cells. However, the muscular layer appears tumor-free, and this may permit quite a good survival rate. So this is early gastric cancer. You'll have to look for these cells, signaturing cells, poorly differentiated gastric cancer cells. Now we have the slide of the large bowel, and we are studying an idiopathic inflammatory disease which starts from the rectum and continuously influences all the mucosa. However, as you can see, it does not affect the other layers of the large bowel wall. Look, all inflammation is confined in the mucosa. The submucosa is free of inflammation, and the muscular and the subserosal fat. So let's have a look at this inflamed mucosa. Here we have some sort of activity because there is a collection of neutrophils. However, close to the muscularis mucosae, we see that here are some eosinophils and plasmacytes. So this basal plasmatocytosis favors the diagnosis of an idiopathic enteropathy in the present case, taking into account the continuous involvement of the large bowel only and the confinement to the mucosa. This is consistent with ulcerative colitis. Another diagnostic feature is the disruption of the architecture of the crypts, which see that they are no longer in parallel and their shape is irregular. They form, look here at the base near the muscularis mucosae, all these architectural irregularities are consistent with idiopathic inflammation. Look here. They are no longer in parallel. They make, look here, look here at this periphery of the crypt. This is architectural distortion. What else do we see? Here we have some endocryptic microabscesses with neutrophils. So this tells us that the ulcerative colitis is in an active stage. Here we have the ulcer, destruction, granulation tissue formation here. And another interesting feature, here you see that some crypts have ruptured. If you see granulomas here, it is consistent with ulcerative colitis. It is not consistent with Crohn, because Crohn wants granulomas irrelevant to ruptured cysts. If you see a granuloma close to a ruptured cyst, this is not typical of Crohn's disease. It can happen in ulcerative colitis. And here you see again the architectural disruption. You see this irregular shape in this crypt. Take a look here. And more importantly, something that may lead to prophylactic colectomy is dysplasia. It can be postulated here, however, due to the activity of the inflammation, you are not sure. You see mitosis. You cannot tell if we are up in the lumen, close to the lumen, where mitotic activity is not normal. So you see some sort of pseudostratification. These are indicative features of dysplasia, quite indefinite. So what do you tell the clinician, the gastroenterologist? Give the medicine so that the activity of the inflammation leaves. And you perform another biopsy. If these epithelial alterations remain, it was dysplasia. And when dysplasia is of high grade, then it may lead to cancer. So you could think that the patient may benefit from a prophylactic colectomy. And what else do we see here? We see all this increased number of plasmacytes, easily discernible. You see the plasmacytes, typical plasmacytes, which characterize the idiopathic inflammation of the bowel. So that was the slide of a chronically active ulcerative colitis. And then we'll have the adenomatous polyp that we see here. It is exophytic, you see. And let's look at its configuration, the architectural pattern. This is a conventional adenoma being composed of villi. You see, here are the villi, the villus component of its architecture with the stalks. This is a villus, this is another one, you see? But it is also composed of tubules. Here they are, the tubules. So this is a tubulovillus conventional adenoma. Tubulovillus conventional adenoma. The dysplasia is of low grade because it mainly consists of pseudostratification, low grade dysplasia. There is no invasion beyond the muscularis mucosae because this invasion would be synonymous to the malignant transformation of the polyp. And take notice that it is not the same as in the stomach. In the stomach, when you see invasion of the lamina propria, you perform gastrectomy. Here, you think of colectomy when you see the neoplastic cells in the submucosa, in the adenoma's stalk, as is the case here, because we have a pedunculated adenoma. That means an exophytic adenoma with a stalk. What is the stalk? The stalk is the submucosa following the exophytic compartment of the adenoma. If you see true invasion within the stalk, the submucosa, then you think that colectomy should be performed. But it's not the same when you see invasion here in the lamina propria. What happens here, as far as malignant transformation is concerned, is synonymous to in situ neoplasia or dysplasia. But what happens here in the submucosa, this is true invasion, not pseudo-invasion, like this well-rounded projection of the adenomatous mucosa in the stalk. This is not true invasion. There is no irregularity, no desmoplasia. This is just a projection in the submucosa, not true invasion. Yeah.
Can you show again which one was invasion?
It could be misinterpreted as invasion here. Why? Because it is in the submucosa. You see here, this is the muscular layer, the submucosa, forming the pedunculated adenoma's stalk. So the stalk is submucosa. If you see something in the submucosa, look here. However, it is not highly dysplastic. You can see also quite normal crypts and adenomatous crypts like this one. But more importantly, the whole contour is smooth. It is not invading. This could be some sort of a diverticulum, perhaps, something going down the wall of the intestine. Okay? So this is a benign adenomatous polyp. Have a look at cancer now. Look here. We have tubular structures clearly invading the submucosa. In their lumen, necrotic material is often found. We have cribriform formations, indicative of moderate differentiation, and tubular cancerous formation, well distinct one from the other, consistent with high differentiation. With one word, we call this low-grade colorectal cancer, not high-grade. And we have the invasion in the wall of the intestine, and we have here the muscular layer being involved. Let's have a look at the subserosa. It's okay here, it's clear. Here we have the muscular layer, here it is, being invaded by the cancerous glands. You see, it's very clear. This is invasion of the submucosa, yeah. Adenocarcinoma. You see, it starts from the mucosa and goes down, it passes the muscularis, mucosae and invades into the submucosa and into the muscular layer. Here the subserosa, and the serosa, this is the serosa, this is the subserosa, is free. In the other section, this one, I think it's the same. You see invasion of the muscular layer of the wall, it's the same. This one, however, is different, I think. Yeah, truly. How can you grade this tumor? Have a look at the malignant cells. You see that glandular differentiation is not so easily recognized. You have some sort of solid-like structures. So this is high-grade colorectal cancer. It is poorly differentiated, this type of cancer. And in contrary to the previous one, what do you see here? Which tissue is here invaded by the cancerous cells? Look, subserosa. So this gives it the stage PT3. Because if we have invasion of the muscular layer, we have pathologic stage T2. Okay? And if we have invasion of the submucosa, we have pathologic stage T1. It's not the same in the stomach. In the stomach, when you have invasion of the lamina propria, it's T1. That's why you perform gastrectomy. For the bowel, T1 is invasion of the submucosa. That's when you consider colectomy. Yes, please.
So you said this was of the subserosa invasion?
Yes, I'm afraid it's T3. Yes, it's. You see the fat tissue. You see the fat tissue here. It's too close. Cancer is too close. However, it's not T4. That means it does not erode the serosa here, the mesothelial lining of the visceral layer of the peritoneum. So that was a high-grade carcinoma. And see at the surface, what do you see here at the surface? How would this look like? It would not look exophytic because it may not be related to a pre-existing adenoma. Here it is ulcerated. So you see that the surface of the carcinoma is ulcerated. That's why I told you. If you see ulceration in a mucosa, it could be inflammation, but it could be cancer. So take a good biopsy with viable tissue to see it under the microscope and tell the clinician if it is cancer or inflammation that causes the ulceration. Any other slides? No, we've seen them all. And the last series is the liver pathology. It's okay. I think I'll manage. I'll manage the liver pathology as well. So have a look at this liver biopsy and please try to identify, this is most probably a central vein, perhaps, in the center of the lobule. But I want to find a portal tract, because you see all these septa with inflammation. This is indication of an activity in the hepatitis. And you see also periportal hepatitis. You see the immune cells passing through zone 1 of the liver, the hepatic lobules. This is the capsule. Have a look here. Here is the portal tract. You have the portal vein distended, the hepatic artery. You see the muscular layer? It is an artery, so it has an organized muscular layer, while the vein, despite being bigger, does not have such a well-developed muscular layer. And what can this be here? The bile ductule, yes. You see it has epithelial lining in contrast to the other two constituents of the portal tract, the portal vein and the hepatic artery, which have endothelial lining. So we see inflammation here, chronic inflammation, immune inflammation, hepatitis, and you see that the cells, the lymphocytes, pass the border in the margin of the hepatic lobule, and this is a sign of activity of the inflammation. It's some sort of chronic active type of inflammation. Let's have a look here. They are closely related to zone 1. And furthermore, you can see that there is some sort of fibrous tissue septa joining portal tracts, possibly. Yeah, portal tracts. And this might also mean that we are in a pre-cirrhotic stage. Of course, if you have a subcapsular piece of the liver, then perhaps some degree of fibrosis is noticed without being cirrhosis. However, you should take it into account because you see septa, fibrous septa, with areas of inflammation joining portal tracts. You see here? The septa starts from this area. Could this be a central vein? I'm not sure. And you follow the septa, and see it ends here in the portal tract. So it either joins two portal tracts or a portal tract with a central vein. And this disrupts the architecture of the liver parenchyma. Okay? So that's what you see in this slide. You see periportal hepatitis, that means lymphocytes leaving the portal tract and entering zone 1. Here is Dr. Pergaris, yes, which will make the comments on the liver slides instead of me. You came at the right exact time. You find the right person.
You're studying liver?
Liver, yes, we're studying liver now because Dr. Pergaris is an expertise in liver pathology. I am an expertise in everything. That means in nothing. It's not necessary, Alexandros. I think I can manage because we describe basic lesions now. We describe some sort of septa joining portal triads.
I'd say that this is cirrhosis.
Yes, this is from.
The larger picture, I'd say that this is cirrhosis.
Yes, you could think that this is a cirrhotic nodule here. However, it is in the form of a biopsy, and what I was saying is some sort of a periportal activity here of the inflammation.
Exactly. So you can see that the offending agent is still there, and the procedure is ongoing, and this may end up to full-blown cirrhosis. You already have bridging fibrosis.
Bridging fibrosis, yes. I explained that to the students.
You
Yes.
have the regenerative nodules. You see that the nodules are
Come closer, Alexandros, so that you can.
They can see
the microphone. Yes.
Okay, so you can see that the nodules are already circular in shape, which means that they are regenerative. You are in that phase. And you can see that hepatitis is active. The offending agent is still there. It's a procedure that is ongoing. And if it's not dealt with, it will end up to a full-blown cirrhosis in the end.
Like the next slides, we'll pass them quickly. Here we have the cirrhotic. You see here? Here are the nodules.
Yes.
You see how clear they are? Look,
yes.
the nodules. Yeah.
Okay, well, we use many terms to describe. You have bridging fibrosis, and then when you use the term septa, then you are implying that you are at the stage of cirrhosis. So we use the term, it's a little bit
Relative.
It's a little bit relevant, the use of terms. But what we do is we use bridging fibrosis to say that it's not a well-built septa yet. But when you're talking about septa, whether it is...
look, here we have active cirrhosis, you see? They pass in the cirrhotic nodules, the inflammatory cells. Active.
But when
this is activity in cirrhosis.
But when you say that in septa, you imply that, disregardless if they are small or large in diameter, you are implying that you are already at the cirrhotic stage. And you should know that we have many systems grading the cirrhosis, which takes into consideration the diameter of the septa in relation to the diameter of the smallest nodule. So the Laennec system of classification, you don't have to remember everything, just to give you an idea. When you have stage 1, 2, 3, and 4. When you have 4, it's cirrhosis. But there's 4A, 4B, 4C. With this, and this is grading in relation to the diameter of the septa. And more specifically,
It's okay,
and
no
more
problem, no problem. I'm having a break now.
Okay.
No
and
problem.
More specifically, the relation to the smallest nodule, regenerative nodule, to the biggest septa. If you have small septa, medium-sized septa, large and very large septa. Very large septa is defined as twice the diameter of the smallest nodule.
Good.
Exactly. So when you use the answer is this, that when you use the word septa, you are already in the field of cirrhosis, on the stage of cirrhosis.
And another common finding in all cirrhosis, apart from the one being a consequence of primary biliary cholangitis, is the hyperplasia of bile ducts. You see many bile ducts like here.
Ductular reaction, yes.
You see here?
Ductular reaction.
How is this called, Alexandros?
Ductular reaction.
Ductular reaction. Here you see how many they are? All these are reactive bile ducts.
Exactly.
Reactive
and
bile
you can see that they are reactive because you cannot see the lumen.
You see?
You can't see the lumen.
Only the epithelial cells.
Only the epithelial cells. This is ductular reaction. This is, it arises from the canals of Hering, if you remember from histology, where the bile ducts start, you have the bile canaliculi in the lateral surface of the hepatocytes, and in the canals of Hering is where they start to have epithelial lining, and this is where the stem cells reside. They, when you have this condition, especially, as Professor said, in dysregulation of the bile flow, and you have the regeneration, the stem cells are activated, and they form these canals, which we are called ductular reaction. It's the difference between ducts, which is normal, and ductules. In ductules, you can't see the lumen.
Like here. No lumen here in these ductules.
Exactly.
Excellent. So that was the active cirrhosis, and this is supposed to be an inactive cirrhosis. Let's have a look
Yes,
here.
yes, of course, yes, of course.
So were the nodules that we saw here also indicative of cirrhosis?
Yes,
Of course.
of course, of course.
Of course.
When you have the nodules, you are
Like this one.
phase of stage.
However, in this one, there are no inflammatory cells entering the cirrhotic nodules. Thus, it is called inactive.
Burnout, or a burnout cirrhosis.
Burned out.
Burnout. We use the term burnout. Most cirrhotic livers that we receive, especially explants, for example, and in many times in the biopsy, of course, in many occasions, you cannot define the offending agent, what caused the cirrhosis in the first place. This is called a burnout cirrhosis. This is actually very interesting because you can see a cirrhosis induced by muscle D, metabolic associated liver disease, that are so burnout that you can't even see steatosis. Not only you can't see active steatohepatitis, you can't even see steatosis. 0% steatosis. But what caused the cirrhosis in the first place is NASH or muscle D. It used to be called non-alcoholic or muscle D. It's very interesting. It's what we call burnout. You cannot see in the current phase histologically, you cannot define the offending agent, what caused the cirrhosis in the first place, and you just make a diagnosis. You don't make a diagnosis, but you say that based on the clinical information, the original offending agent could be the non-alcoholic steatohepatitis, for example. But this is a burnout. You cannot see anything. It's not an active state.
Yeah, no inflammatory cells.
Very nice example. You can see the normal ducts, the ductules, crowning the nodules in the periphery, and no activity.
No activity.
No inflammation.
Yes, you know I have the eye, I catch the fields, I catch the fields. You know.
But this is a very good example where you use that.
Of course, because I'm the professor.
Yes, it's true.
Now, here is a sort of great damage in the liver. This is hyperacute destruction of a large part of the liver. So you see how greatly everything is destroyed here. And you see the inflammatory cells. What remains, the remnants of hepatocytes.
Little islands of hepatocytes.
Little islands of hepatocytes. However, we have lymphocytes again predominating because this is related to perhaps an immune type of inflammation.
And what else? Can you guess what else you may have heard of it? What drug specifically causes
the drug.
mass? What? Yes, and more specifically, very good. Acetaminophen.
Acetaminophen. Yeah.
Acetaminophen. You may
Is
have
your
heard.
microphone open?
Is it open? Can I be here?
No, it's for the. It is.
It
Yes,
is.
okay.
And it's also a common drug that people use to suicide. Okay.
For suicide reasons.
Yes, for suicide reasons.
Yes.
But I have actually seen an explant, a whole liver specimen from a woman that took acetaminophen, and there was no hepatocyte inside. We couldn't identify a single hepatocyte.
And is all this called necrosis here?
Yes, it's a type of
Alexander?
necrosis. There are dead hepatocytes that
Have a
mix-
seat and show the students the slide.
You can see that you have massive liver necrosis. Ξέχασα την πλέον τριάδα, τα πλέον αισθήματα.
Portal triad.
Portal tracts, sorry.
Portal tract. Yes, please.
The portal tracts are
Turn the light on? Yes, of course.
are very resistant, the portal tracts. You can see that portal tracts are not affected by such situations. They remain in their places, which is, you can see that the portal tract here is almost normal. You can identify the bile duct, the portal duct, you can identify the portal artery, you can identify the vein, but all around the portal tract, you can see that there is no surviving hepatocytes except for these small islands here. In my case, there was not a single hepatocyte surviving.
Viable
Hepatocyte.
hepatocyte.
Yes.
Professor, this is immune mediated.
The specific case, at this stage, when you have such massive necrosis, you cannot easily say.
But when you
But
have
there are signs.
a viral hepatitis, very, very rarely causes this hyperactivation of the immune system. It is an exceptional phenomenon.
Exactly.
The rule is that the organism sends the virus away.
Exactly. There is a very small subset of acute Hep B infections that can cause massive liver damage like this. Very few exceptions. This is not the rule. What causes this is the most
Common.
The most common would be autoimmune hepatitis and acetamin toxicity.
And some poisoning with, you listen, the news, mushroom poisoning from...
Yes,
yeah,
toxic mushrooms.
toxic substances.
And when you want to identify what caused that, it's not, in this setting, they don't wait from the histopathologist because they know if she took acetaminophen or if she did nothing, so probably she has high IgG levels, so it's probably autoimmune. But there are still signs. If it would be autoimmune, what is the hallmark of autoimmune hepatitis in histology? Plasma cells. When you see big groups of plasma cells, you have to think, but still, they don't wait for you because it would be a woman, it would be middle-aged, it would be a very high IgG.
The clinical
The
characteristics.
clinical context will be very clear. In such
You
cases.
talk too much. Who was your teacher?
I don't know.
You talk too much.
From when I was a child, I used to talk.
He was my student in this century, not the previous one.
Yes. Don't let me interrupt you anymore.
No problem. I thank you very much. Just sit here, Alexandros. It's easy.
Okay.
Yes, sit here.
Of course. Okay.
And the other one, now we'll have the hepatocellular carcinoma. We have 2 slides.
Uh-huh.
So you see here all this tissue having a sinusoidal pattern of circulation. However, you see that there is
No
some
what?
degree, you see them only with no portal triads. So it's only liver parenchyma, which is easily identified as such because the tumor differentiation permits such to understand that this is primary in the liver, you see? And so here the main differential diagnosis is from a hepatocellular adenoma.
Exactly.
So you look whether there is some sort of invasion at the periphery.
Exactly.
And you have some atypia, which is not consistent with adenoma.
You have encapsulation, fibrous capsule, which is not consistent with an adenoma. Adenomas tend not to have a fibrous capsule.
Really?
Yes,
They do not have
yes, yes.
to be encapsulated.
Yes, yes. They tend not to.
So this is the case here. And of course, you could see bile production by the liver cells. It could be a sign of liver cell differentiation. And the other case of hepatocellular carcinoma is this one. Pay attention to the adjacent non-carcinomatous parenchyma of the liver. You see here the sinusoids. And here is the cancerous. Here you can more clearly tell that this is cancer because there is some degree of atypia and mitotic. Look,
Activity, yes.
mitotic activity, quite prominent. However, again, we have a grade that we can tell that it is, look here, the sinusoidal pattern, which helps us tell that this is primary and not the commonest malignant type of cancer in the liver, which is metastatic.
Metastasis, of course.
Metastatic. So this is another liver cell carcinoma. You want to comment,
Yes.
Alexandros, on the grading? Or
I
the...
would like to comment on something very interesting, at least to me, okay, that you can see that the neoplasmatic cells are still organized in trabeculae, except for these areas that you have a
So with the mouse. Come here, come closer.
pseudo-adenic, pseudo-acinar. Okay, it's different. Yes.
Come closer.
What can you see here? It's a little bit of pseudo-acinar formation. You can see something like a lumen in the center, here as well. You have the classic trabecular formations, like that. You can see these are trabeculars, and these are the veins where the blood flows. But here, you have a form of lumen in the center, a pseudo-acinar formation, which are linked to beta-catenin mutations.
Beta-catenin
mutations.
Beta-catenin mutations.
Beta-catenin mutations.
Yes.
And let's say a thing or two about the grading. Let's see, as far as the architectural pattern is considered, you can see that these trabeculae are very thick as far as the number of cells that consist them. You can see that it is like 15 cells thick. This is not normal. In normal liver, it must be the most is 2 cells thick. In regeneration, you can accept 3 cells, but when you have 15 cell thickness, this is cancer, and more specifically, this is a macrotrabecular carcinoma. When it's pattern, exactly. Yeah. When you have more than 6 cells thickness, it's a macrotrabecular massive, as we call it. It harbors mutations of P53, and it is much more aggressive than the other. Yes,
I didn't know that.
Yes, they tend to have vascular invasions. They love vascular
yes,
endothelium.
Hepatocellular carcinoma spread hematogenously. In contrast to the next malignant tumor, which is cholangiocarcinoma, which spreads to lymph nodes.
Yes.
macrotrabecular.
Macrotrabecular pattern.
Macrotrabecular massive. Trabecular massive pattern. More than 6 cell thickness in the trabecula.
Great.
When it consists 50% of the volume of the whole tumor, you can call the whole carcinoma as macrotrabecular massive, which means that it will have a worse prognosis, it will have spread through the lymphovascular system, and harbor P53 mutations. P53 mutations.
P53 mutations.
Sorry,
Okay.
Yes.
Do these cancers start from a specific zone, for example, zone 1? They
No,
initiate or
no.
it can be diffused and then...
Actually, this is a very interesting question because we know now that these cancers do not start from differentiated hepatocytes. They start from stem cells. Both hepatocellular carcinomas and cholangiocarcinomas originate from stem cells that in the process they become cancers, exactly, and then they differentiate towards hepatocyte or cholangiocyte.
And there are mixed cases.
And this is how we explain exactly the fact that there are mixed cases of the same tumor containing a compartment that is hepatocellular differentiation and cholangiocarcinoma in another.
We'll see the cholangiocarcinoma now.
So it
because-
can be zone 3 and zone 1 at the same time?
Yes, it could be anywhere because it comes from stem cells, not from differentiated hepatocytes.
Now, and we finish with the two cholangiocarcinomas. Here is one. This one is glandular. So make a comment, Alexander.
Okay, so you can see that the cell has a very different differentiation. There's no formation of trabeculae. There are glands back to back, fused together, irregular. They are not functional. You can't see bile. They're not connected to a normal liver parenchyma, so they can harbor bile in them. They are non-functional. They are empty here.
Bile is produced by hepatocyte, but it is transmitted through
Cholangiocytes. This is not functional. So
Bile
macroscopically, what would you expect to be green in color? Hepatocellular tumor, HCC, or cholangiocarcinoma?
the one that produces the bile. So
The HCC.
hepatocellular
This
carcinoma.
that you expect to be green in color. So you have back-to-back glands, you have severe atypia, you can see that they are fused, they have no function, you can see the severe atypia, okay. Cytologic pleomorphism, you can see that there's nuclear pleomorphism. One nuclei is much bigger than the next one, and you can see that you have open chromatin. All of these are signs of neoplasia, and it is developed in a thick fibrous tissue, thick fibroblastic tissue intervening between the canals.
Yeah.
Okay.
And there is another case of cholangiocarcinoma as well. Here is the normal parenchyma of the liver. So there are two types of primary liver tumors, hepatocellular carcinomas and cholangiocarcinomas. Let's see, that's the one we saw, I think. The other one is this one. Let's see if there is something different here. What are these?
I'm not sure.
These are two
It's a small duct type.
small, eh?
Yes, it's small
Too
duct
small.
type.
Another type of
Yes.
cholangiocarcinoma.
Yes, we differentiate between the large duct type cholangiocarcinoma. Okay, this is a little bit advanced for law students. But okay.
Our students are in the advanced
Okay,
level.
okay. I mean,
no problem.
you don't have to remember all this, but okay, still. There is large duct type carcinoma and there's small duct type cholangiocarcinoma. We differentiate that based on morphology, of course. You can see small ducts here embedded in a thick fibrous fibroblastic stroma. And when you have a biopsy, where you don't have the whole tissue and you have to make the diagnosis, the very helpful stain would be EMA. EMA
really?
stains both all cholangiocarcinomas, but in a different pattern. When it's a large duct type, you can see the membranous whole cell or cytoplasmic staining, but when it's a small duct type, the EMA would stain only here, the apical surface.
I see. And what, from the clinical point of view, what's the significance in differentiating these two
The larger
subtypes?
types have worse prognosis.
The large,
So you
the
kind
large,
of have to...
large duct
Actually,
large duct
there's a
types
second one.
are worse.
Have a worse prognosis, and when you have large duct type, it could be extra hepatic in origin. But when it's small duct
Coming
type,
from the
it's usually
extrahepatic
exactly. But when it's a small duct type, usually it's intrahepatic.
Intrahepatic
So this is
cholangiocarcinoma. Because similar tumors can arise from the extrahepatic bile ducts,
Exactly.
not the intrahepatics. So, we covered oral threats. Thank you very, very much, Alexandros, for your valuable contribution to our study. And so, you have a nice weekend. Okay, all right? And see you next Monday. Let me turn it off. Okay.